In this lecture, we will discuss a junctional escape beat, including its origin, mechanism, and EKG features. A junctional escape beat occurs when the normal pacemaker fails to fire and the next available pacemaker in the conduction system fires in its place. In other words, the AV node senses that the sinus node did not fire an impulse, and therefore when its turn comes up, it reaches its threshold potential and the pacemaker fires. So if you look here, what we have going on is this is our sinus node, and notice there's an X in it, okay, meaning that it's not firing, okay? And what happens is none of these atrial pacemakers are firing, and eventually this AV node then fires when its turn comes, okay? Remember, we go from the fastest to slowest pacemakers, the sinus node setting the rate, okay? But if nothing's coming from above, our AV node acts as almost a safety net and fires because it didn't get anything from above. Okay. Now, if you recall, the normal intrinsic rate of the AV node in adults is generally between 40 and 60 beats per minute. This corresponds to an interval of 1.2 to 1.6 seconds between complexes. This may be slightly different in children, although the idea here is still the same. Okay. So remember, the intrinsic rate of the sinus node is between 60 and 100 beats per minute. Okay. Then we have our AV node between 40 and 60 beats per minute, and then we have our ventricles around 20 to 40 beats per minute. Okay, so imagine we're coming to a point of beats fired. We're going at normally at 60 beats per minute, and then eventually this one goes longer and it's not getting an impulse. Okay, so what happens is the AV node fires and we see it coming from there. Okay, so beyond that 60 beats per minute in that zone. So that's pretty much what we'll be discussing here. Now, one instance in which we can see these junctional escape beats is during sleep, especially in children. So why would that be the case? Well, think about it. If the rate of the impulses arising from the sinus node slows so much during sleep, the AV node may take it as if the sinus node isn't working properly. So it steps up, it serves as a backup mechanism by firing an impulse. It then gives the sinus node a chance to fire again. If it receives an impulse from the sinus node, sinus rhythm will continue. If not, the AV node will fire again in its place. Okay, so just think of the AV node as that safety net for the sinus node. This sort of activation of the AV junction caused not by an inherent problem in the sinus node, but rather failure of the sinus node or more rapid atrial pacemaker sites is referred to as a junctional or nodal escape beat. Hopefully that makes sense. Okay, so what about the EKG? What can we see here? Well, in general, if you look at the EKG and you see these QRS complexes that are regular and narrow, which denotes a supraventricular rhythm, meaning it's coming from above the ventricles, and P waves that are difficult to make out, then you're likely dealing with some sort of junctional or nodal rhythm or beat. Okay, and if you see this sort of configuration in a beat that occurs later than you would expect, then we call this a junctional escape beat. So again, if you look here, this is our P wave, our QRS complex, and our T wave. Okay, and then the cycle again occurs: P wave, QRS complex, and T wave. All right, our normal R to R interval from this R wave to this R wave is occurring here. All right, and then we would have another complex, but notice that our P wave is not occurring. Okay, it would come somewhere in this area because this is where our next QRS complex would come. However, we don't have that occurring, so again, we're waiting for the beat, nothing's coming, so all of a sudden the AV node senses that and it releases its own beat. Okay, and because of that, notice our junctional escape beat, this here, okay, there is no P wave present, although it may be present either buried within or maybe slightly before or slightly after. Okay, and we'll talk about that shortly, why that's the case. Okay, but what I want you to take away at this point is that we don't see that P wave early on like in a normal complex, okay, with a normal PR interval. Instead, we see this complex coming later, after where the next complex should come, okay, and later than expected. So we call this a junctional escape beat. Okay, and notice that the QRS complex that we're seeing here is normal. Okay, so normal QRS complex to all the other similar underlying rhythm. Okay, so that's the general overview. Now let's look at this in a little more detail. So we said the junctional escape beats arise from the AV node, and therefore activation below that region, that is activation of the ventricles, will typically be normal. In other words, there is normal antegrade conduction of the impulse down the normal electrical conduction system of the ventricles, and thus normal intraventricular conduction. As a result, the QRS complexes, we said, will be identical to the underlying rhythm's QRS complexes, typically normal and narrow. Okay, and we saw that here, normal and narrow QRS complexes similar to the underlying rhythm that we saw. Remember, what we have going on is similar to that premature junctional beat in this case that it's coming from this area, and everything below, as it conducts anterogradely to the ventricles, will occur normally. Okay, so there's no issue going down our system. It's just where is that beat originating from? Okay, so that's why we see similar QRS complexes. Now, there's also retrograde conduction to activate the atria. And because both ventricular and atrial depolarization are happening nearly simultaneously, the QRS complex and the P wave will appear together. Depending whether the impulse origin is high, mid-level, or low in the AV node, we can see the P wave at different areas relative to the QRS complex. For example, at times the P wave may be buried within the QRS complex. Okay, as we see here, we cannot really make out the P wave, so it must be pretty much buried somewhere within here that we can't make it out. All right. Now at other times you may see an anterograde P wave or retrograde P wave. An antegrade P wave is simply a P wave that appears before the QRS complex, and a retrograde P wave is one that appears after the QRS complex. Okay. So again, this is similar to what we discussed in the premature junctional beats. So what we have going on here, let's just erase some of this so we can make this clear. Okay. So we have if they both occur at the same time, meaning that the beats coming from here, the ventricles and the atria become depolarized at the same time, then it would occur somewhere within that junctional escape beat, and we wouldn't see the P wave. Okay. Now, if it was a more higher origin, imagine it up here, the atria may be depolarized first, and then the ventricles a little later. And in such cases, we may see a P wave that may be inverted in these leads, okay, because now it's going in the other direction. So that may be inverted and also coming before our complex because the atrial were depolarized earlier. Now, what if it was occurring lower in the AV node, in which cases the ventricles were depolarized before the atria? All right, in such cases, the QRS complex would come before, but then afterwards, we may see a small inverted P wave occurring after our QRS complexes, indicating that the ventricles depolarized first, our QRS complex, and then the atria representing the P wave. Okay. Now, as we previously mentioned, both the atrial and ventricular depolarization occur nearly simultaneously, and because AV nodal conduction makes up the majority of the PR interval, we will end up having a very short PR interval, or at least less than normal, and sometimes it may be even absent. This is due to the fact that the impulse is originating from the AV junction. Okay, so again, remember, PR interval represents most of that AV nodal conduction, okay? And because we're originating right here, we're not going to really have much of that physiologic delay, and we'll have a short PR interval if it's even present. Remember, it could be buried within the QRS complex, and we might not even have one at all. So atrial depolarization occurs in a retrograde fashion, and therefore we're going to see these abnormal P wave axes. Okay, instead of the mean electrical P wave axis heading leftward and inferiorly, giving upright P waves in the inferior leads like in sinus rhythm, we will instead have the P wave axis going in the opposite direction in the frontal plane, leading to inverted P waves in the inferior leads, 2, 3, and AVF, and upright P waves in lead AVR. That is, if we are able to even make out P waves. Remember, they could be buried within our QRS complex. So again, let's look at this. Now we're talking about our P waves. We mentioned these inverted ones. So let's just know that our normal P wave axis is between 0 and positive 75 degrees, heading in this direction. So if we put our leads here, imagine lead 2 that sits at positive 60 degrees. Okay, we have lead 3 here, lead AVF. All right, lead 2, imagine this red arrow, their P wave axis heading towards lead 2, so we'd see upright P waves normally in sinus rhythm. Okay, lead 1 would be here, AVR is here, so we would see inverted P waves in sinus rhythm as it heads away from lead AVR. Now what we're saying is that we have the rhythm originating from within the AV node. Okay, so now it's heading in the opposite direction. Okay, so imagine it going in this direction, or at least towards AVR. That's why we'll see these positive upright P waves in AVR and negative P waves in these inferior leads. Okay, so inverted P waves in the inferior leads, upright in AVR, because of this abnormal P wave axis. Okay, and remember, it's not always the case that we can see P waves. They could be buried, as we see here, within our QRS complex. Okay. Now, because the beat occurs later than expected, the R to R interval will be longer than you would normally see during sinus rhythm. In other words, the distance of the junctional escape beat from the preceding complex is always longer than the normal R to R interval. Okay, and we saw that earlier where we were looking at the R to R interval. So we'll just take another look at this. So here's R to R interval. Okay, and the next R wave should occur here, but it's occurring later. Okay, when we talk about premature junctional beats, it would occur earlier, but this one's later, and that's a junctional escape beat. Okay, now because the normal pacer did not fire, we get a non-compensatory pause. The junctional beat will reset the pacemaker to a new timing cycle, and it may even be at a different rate. We call this a non-compensatory pause because because the beat following the junctional escape beat does not compensate for it, and overall timing of the beats that follow are affected. So if we look here, we're saying that we have a non-compensatory pause. So meaning this R to R wave, okay, if we were to have this, okay, the next R wave should occur somewhere here. But instead, this junctional escape beat coming from here is going to travel back and reset our sinus node, okay? And doing so, it will either fire at a similar rate that it was previously or reset it. So you pretty much have a reset going on here as it travels back, and notice our sinus P wave is firing again, and it may be at a different rate. Okay, so it's resetting what it was before, and either of those intervals will be the same or it can fire at a different rate in different intervals. Hopefully this is making sense. Now let's briefly run through our chart before we end here. So junctional escape beats occur when the sinus node fails to fire. The impulse originates, we said, from the AV node, the AV junction. We have anterograde conduction to the ventricles, retrograde conduction to the atria, and with that retrograde to the atria, we get a reset of the sinus node, okay? And because of that resetting, we get a non-compensatory pause where the overall timing is actually affected. Now we said you should notice that this is an irregular rhythm, right? This should make sense. We don't have regular R to R intervals throughout. Instead, we have one that's occurring later. So we have an irregular rhythm. The underlying rate depends on whatever the rhythm was, okay? Now, in terms of the P waves, we said either the P waves could be buried in the QRS complex, in which we wouldn't see one. They could come before or after, depending on which got depolarized first, the atria or ventricles. We'll have an abnormal axis if we can see the P waves, where they would be inverted in our inferior lead, 2, 3 in AVF, and upright in lead AVR. We will either say no P to QRS ratio if there's no P waves present, or there could be a 1-to-1, all right, in which we would have the antegrade or retrograde P wave present, okay? Now, in terms of the PR interval, again, if it's buried within our QRS complex, we won't have one, because remember, our PR interval makes up from the P wave up until our QRS complex, okay? So this is our PR interval, and if the P wave is buried within here, we're not going to actually have one, okay? Now, if you do see a PR interval, you should note that the PR interval, or what we see here, that does not represent atrial stimulation of the ventricles. In other words, it doesn't mean that the atria are firing, okay, and traveling through into the ventricles. Instead, the origin is coming from the AV node, as we mentioned here, and traveling retrogradely. The QRS interval will be normal, or whatever is the underlying rhythm, okay? There should be no change there because everything below here is occurring normally. There should be no grouping, and obviously there is a drop beat, right? We're missing that beat, the P wave, and instead we're getting this junctional escape beat occurring. Well, that's the end of this lecture. We discussed junctional escape beat, including its origin, mechanism, and EKG features. I hope you learned something.